Hi, this is Amir Kheradmand. In this talk, my goal is to give you an outline of some considerations and findings related to vestibular symptoms in patients with vestibular migraine. If we look at the criteria for vestibular migraine, it has taken shape as a diagnostic entity that affects up to 1% of the general population. This is great because the lack of a universally accepted definition of vestibular migraine can hamper patient identification in clinical and research settings. But for those of us who consult patients with vestibular migraine, we can see that these criteria do not cover many patients who have dizziness and migraine features, but they do not frequently occur together. That's why the Baranier Society has recognized another category of probable vestibular migraine in which only one of the criteria B and C above is enough to consider the diagnosis of vestibular migraine. In other words, dizziness and migraine features do not need to occur together to consider the diagnosis of vestibular migraine. Looking at these criteria also brings us to a major gap in understanding mechanism of dizziness in vestibular migraine. Currently, the diagnostic criteria are mainly based on the subjective quality of symptoms, and there's no objective measure of vestibular symptoms in these patients. Here, I'll go over some findings related to measurement of perceptual aspects of dizziness in patients with vestibular migraine and highlight the need to apply such measurements for understanding higher order neural mechanism of dizziness and also developing biomarkers for diagnosis. Clinical research into dizziness in recent decades has mainly focused on the low-level vestibulo-ocular function within the labyrinth or the brainstem. And we have paid little attention to perceptual functions of the brain, for example, the cerebral cortex, including its role in spatial orientation, which can be directly linked with the disabling symptoms of diseases affecting the vestibular system. When it comes to vestibular migraine, what we know is mostly based on general understanding of migraine pathophysiology. In such context, the diagram here shows possible mechanisms involved in the pathogenesis of vestibular migraine. The trigeminovascular system is the anatomical substrate, and its activation and sensitization, along with the nociceptive brain centers, can cause headache. Related to this hyperactivity, abnormal sensory modulation or integration within the thalamocortical network could result in dizziness and spatial disorientation, and also altered activity in the vestibular system could lead to transient vestibulo-ocular dysfunction or vestibular hypersensitivity with migraine features. Regarding the pathophysiology, there are actually a few studies, each with few patients, that have provided functional imaging data. These studies suggest involvement of the multisensory vestibulo-thalamocortical network in the pathophysiology of vestibular migraine. Comparing ictal with interictal images, increased metabolism in the temporoparietal cortex and decreased metabolism in the occipitotemporal and posterior parietal cortex has been found. Another study has found decreased gray matter volume in the temporoparietal cortex, which is the area of convergence for multiple sensory modalities, including visual, vestibular, and somatosensory inputs. How about perceptual dysfunctions? In 2011, the work from Lewis and his colleagues found that patients with vestibular migraine had lower threshold for motion detection in the role plane at lower frequencies when compared to patients with other types of migraine or healthy controls. In other words, patients with vestibular migraine had higher sensitivity to motion with lateral tilts. But how about spatial orientation? Well, normally we maintain a stable perception of the world in upright orientation despite changes in our eyes, head, and body position. And for that, our brain relies on multiple sensory input. Here's an example. When we tilt the camera back and forth in front of a painting by Rothko, the images move in the opposite direction of the movement. But we know that when we tilt our head, the image stays steady despite suboptimal viewer compensation in the role plane. So our brain, like any other sensory motor system, must be able to integrate sensory inputs into a common reference frame for coherent spatial orientation, which can be actually a demanding task. This can be actually examined using the subjective visual vertical task, in which spatial orientation is measured as the perceived direction of the gravity. So the task is to report which way is up by comparing the orientation of a line to perceived vertical orientation. In the SVV task, the brain has to rely on information about the head and body positions in the space and the eye position in the orbit in order to determine the orientation of the visual line in the absence of orienting cues. There are normally systematic errors in this process with head tilt, which reflect challenges in maintaining spatial orientation. So in upright position, where the head axis and the physical vertical are aligned, the errors in spatial orientation is very close to vertical. With the small head tilts, the errors are usually in the opposite direction of the head tilt, which is known as the E effect. And with larger head tilts, more than 50 degrees, usually the errors in spatial orientation are in the direction of the head tilts, which is known as the A effect. So knowing the pattern of change in spatial orientation with head tilt in the study, we asked, do patients with vestibular migraine have abnormal spatial orientation during head tilt when the brain is challenged to maintain the common sensory reference frame? We found that patients with vestibular migraine had larger error in spatial orientation with head tilt, or in other words, they had larger A effect. Here, the patient errors is shown in red and the controls are in blue, and with head tilt, there is about 4 degrees of error in the opposite direction of the head tilt. Just so we get a sense, campanile of Pisa is tilted about 4 degrees, so perceptually this could be a significant tilt. Another study has found that patients with vestibular migraine had elevated vestibular perceptual thresholds after adaptation to visual motion. In this study, perceptual threshold was the time between the onset of the motion and patient reporting the direction of the motion, and the vestibular ocular threshold was the time elapsed between the motion and the onset of the nystagmus. So here's before and after for vestibular ocular thresholds, and before and after for vestibular perceptual threshold. The vestibular perceptual threshold was dissociated from the vestibular ocular thresholds in patients compared with controls, suggesting altered sensory weighting of visual and vestibular signals that encode motion perception in these patients. This is another study that does not directly examine vestibular migraine, but its finding could be relevant to the pathophysiology. This study compared ballet dancers to healthy controls. They found that ballet dancers show shorter duration of VOR and perception of rotation with whole body rotation. There was selective reduction in the gray matter of the vestibular cerebellum in dancers, which correlated to shorter perceptual responses, but that was not the case in controls. So if we want to put these findings into a perspective, there's likely a dizzy spectrum. At one end of the spectrum, there are vestibular migraine patients that have high level of symptoms and low perceptual thresholds, and at the other end are dancers with high perceptual thresholds and a low level of symptoms. And in the middle, there is an average population. So perhaps a successful treatment would be the one that can move vestibular migraine patients towards the average population. So to conclude, currently vestibular migraine is only a clinical diagnosis, and lack of objective measures can hamper efforts towards understanding its pathophysiology. Recent studies suggest abnormal motion detection threshold or larger errors of spatial orientation, which show high-level dysfunction related to vestibular processing in these patients. Gaining insights into central processes that result in dizziness, vertigo, and spatial disorientation in these patients is an important step toward making diagnosis and effective treatment strategies. So, we have included more details in a recent review here in the Journal of Cephalalgia, and if you're interested, you can go through this review paper. And with that, I would like to thank you for your attention.